Hello, everyone. Thanks for joining us for our October Strengthening webinar. Today, we get to hear updates on DULCE, which is a model bringing the Strengthening Families approach to the healthcare setting. I know a lot of you have heard a little bit about DULCE and been very intrigued by it, so I'm happy that my colleagues are joining us today to share what's going on with it now. So let's get us started. Just a little bit about these webinars in case you're new to this. These are monthly webinars that anyone is welcome to join if you're using the Protective Factors Framework or coordinating Strengthening Families efforts, whether that's for your organization or your state or something in between. We jointly convene these between my organization, the Center for the Study of Social Policy, or CSSP, and the National Alliance of Children's Trust and Prevention Funds. Each month we have a topic, usually with a guest speaker, who covered for webinars you may have missed. We've shared a lot of great information on these webinars over the years. All right, so what's coming up? We do this the second Thursday of each month, so our next meeting will be on November 14th. We're going to hear about some innovative training approaches, including some online modules for child welfare workers in West Virginia, and we'll hopefully have a couple different examples shared and then some time to discuss other ways that you're getting training out to folks to bring people up to speed on a Protective Factors approach. The dates are listed there for our other upcoming webinars, always the second Thursday of the month, unless we let you know otherwise. But I think we've stuck to the second Thursday for the last 5 years or so. And you can just put that on your calendar, and if the topic is one that's interesting to you, go ahead and register. We also always announce these webinars in our Strengthening Families e-update newsletter, on our CSSP events page, on the Alliance's Google site, and on social media. So just and then we'll get into our main topic, where I'm joined by two of my colleagues, Cassie Hampton, who is also a senior associate at CSSP like I am, and Dr. Bob Sagi, who is at Tufts University and also a senior fellow at CSSP. So a couple updates from CSSP. We just launched a new section of our website that I wanted to share with you all. CSSP does a lot of work around equity and justice, and recently decided to make that more visible on our website, because we actually have a lot that we can share and would love to share with folks. So you might want to take a look. I'm scrolling through this right now. This is a sort of overview of all of our equity work. And I wanted to point out just a couple of the pieces. We recently put out a document about our own journey to center equity, inclusion, and justice in our work, which is really interesting, and also might have some lessons you could apply to your own organizational or community level work. And we've got one of the pieces I wanted to point out. Oops, sorry, there's a video. I'm not going to show it. Just encouraging you to go check this out. Listing some of our offerings that we can provide: technical assistance, policy analysis, an insight training that we recently developed, institutional analysis, leadership development. So we do have a strong bench of professionals who have a lot of expertise and wisdom to share on these issues and can help an organization or community work through advancing equity in their own communities. And one piece in particular that I thought might be interesting to all of you, excuse me as I scroll through this, you can see there's a lot to dig into, is a glossary of key equity terms. So we had an internal working group that went through and defined, I think, about 70 terms. Sometimes, you know, these terms change over time as the field changes and as perspectives change. but we wanted it to be current, up to date of the terminology that we use in our own work, and you may find that useful for your work as well. Or you may, want to look something up because you're not sure what we mean by it, or you're wondering, what the sort of preferred way to say something is. You can look at our definitions and see if that works for what you're trying to convey in your organization. So I encourage you to check that out and contact us if you've got questions. All right. A recent document that came out I wanted to share. It's called Legal Partnering for Child and Family Health. It's actually closely related to what we're going to hear about today from DULCE. This was written by Samantha Morton of MLPD and Stephanie Doyle from CSSP. It spotlights best practices for working with the public interest law community to advance early childhood work. And they are actually doing a webinar today as well. So if you go to where that document is posted, you'll be able to watch a recording of the webinar. But we are also going to have Stephanie and Samantha present on one of these webinars in early 2020, so keep an eye out for that. And they'll really talk about concrete support in times of need and the role that legal partners can play in helping to meet families' needs in early childhood settings, which again, we're going to hear more about today with DULCE in particular. So I hope that's of interest to a lot of you. I encourage you to check out the brief and either watch their recorded webinar or stay tuned for when we do a webinar in this space in the next few months. And just as a reminder about a conference coming up just about a year from now in Seattle, October 13th through 16th. It'll be the second time we've convened the Together for Families conference, and we're very excited that this year we're bringing in some new co-hosts. So Be Strong Families, a longtime national partner, will be co-hosting the conference as well and bringing their expertise in parent cafes and other models as a parent-facing organization. We also have Families Canada joining us, which is the equivalent in Canada of our National Family Support Network. So we should have some nice international perspective participants, and being so close to Canada there in Seattle, it'll be a nice opportunity to connect with our colleagues from the north and learn more about the work that they're doing. So I encourage you to put that on your calendar and look for more information coming as we get into 2020. All right, Martha Reeder is going to share some updates from the Alliance.
Thank you, Kaylin, and hello, everyone. I want to just share with you a quick opportunity that I hope you will be interested in. The Alliance National Parent Partnership Council is launching their Partnership Academy through a Need to Know webinar series. We at the Alliance are pleased to offer this opportunity both to our own Children's Trust Fund network and to all of you to learn more about some valuable resources we have and help you think about how they might be useful in your work. We work closely with the ANPPC, with the Council, to create multiple tools and resources that you can download at no cost from our website. And during this webinar, we will review some of these tools and some recommendations for how they can be used. So if we'll look at the next, there's the registration link for the webinar, and I'll copy that into our chat box so you can have that later. We will be using some interactive tools that will encourage good virtual conversations. So please invite your parent partners or your potential parent partners to attend the webinar. We will be digging into what are the basics when organizations want to partner with parents to accomplish common goals, and things like how do you begin to build the relationships that can lead to effective and meaningful partnerships. So we hope you will really join us as we start on this exciting journey. This is the first in a series of webinars, and we will be sharing many tips and tools to help get your wheels spinning. So that's all I have for today. I hope you will plan to join us.
Thanks, Martha. All right, that brings us to our main topic for today, which is DULCE, stands for Developmental Understanding and Legal Collaboration for Everyone. I want to quickly introduce my friends and colleagues who are presenting today. Kathy Hampton is the Project Director for DULCE at CSSP. And Bob Sagi is the pediatrician and the director of the Center for Community Engaged Medicine at Tufts Medical Center. They've both been working on DULCE for several years and have a lot to share about how this is transforming early childhood systems and clinic practice and opportunities to bring it to other locations. So With that, I'm going to hand it off to Patsy.
Hi, everyone. I'm so glad you could join us, and we're super excited to share information about DULCE today. As Kaylin said, DULCE stands for Developmental Understanding and Legal Collaboration for Everyone. And I just want to break that down a little bit. So developmental understanding means in this case that we're promoting parent knowledge of child development and parenting in collaboration and in partnership with parent-child relational approaches. We're using touch points right now as a way to highlight that important period of time in child development. Legal collaboration means that we are helping families access the concrete supports they want and are legally entitled to. And for everyone in DULCE means that we're reaching families where they already bring their babies. We offer universal access to all parents of newborns in primary care clinics. So it's an intervention that focuses on children birth to 6 months of age. And throughout this presentation, we'll be sharing about what DULCE is and how we're beginning to expand that work across the country. CSSP has been implementing DULCE for the past 4 years, building on the randomized control trial that Bob led at Boston Medical Center. We're currently operating DULCE in 5 of our EC Link communities, our Early Childhood Learning and Innovation Network of communities, and they have had great successes, and we're ready now to grow the work and branch out into other parts of the country. So at the end of the webinar, we'll be talking a little bit about what implementation looks like and offering ways for you to reach out to us if you're interested. But I thought what we would do on the next slide is I just want to summarize a little bit about what DULCE is, and then we're going to show a video. It brings the protective factors approach to healthcare for infants and their families during the 6 months of life. And as I said earlier, it happens in the pediatric care clinic, in the primary care clinic. So families don't have to do anything different. They go where they already go to their well child visit, and then bringing in the pediatric clinics and the legal partners. And you'll hear about examples of how that happens along the way during the next little bit of our conversation. So with that, why don't we, Caitlin, just go to the video and give you a brief overview. We're super excited. This is a new video. You are the first group to see it live. So get your popcorn.
All right, folks, just getting it set up here. Here we go.
I never had anyone to walk me through my years. My mom lived in a different country at the time, and my father lived in New York. So I was here alone in Florida. There was no one to hold my hand, no one to guide me, no one to give me options as to what resources are there for me. And I was determined that I was going to be someone's resource. DULCE is bringing so many different systems and sectors together who can have profound influences on families' lives, and bringing them together in a structured, humble, and high-impact way that's not about them, it's about families and what families need to thrive.
For the families, we just show up at the health clinic for your routine care, and everything happens. So we try to keep that part really simple. And the interdisciplinary team is what allows us to take the really complex system we have and make it seem simple.
The family specialist, who is the person who actually directly interacts with the family, really is able to develop a relationship with families very early on to help understand what their needs might be and how we can best address them. And then through this amazing interdisciplinary team, we're able to meet those needs fairly quickly, sort of triage what opportunities are there in the community to address food security, housing safety, a variety of concrete supports that a family might need.
We've been screening for years for domestic violence, say, but when we had a positive screen, we didn't really have a next step to take. Sort of a panic and a rush and trying to get the right person on the phone. DULCE has sort of forced us to streamline some of these things to really develop protocols that work efficiently and build the connections to referral organizations, both within the hospital and outside our own system.
The allied professionals are able then to kind of wrap their loving arms around that family in a way that doesn't take away from that provider-patient relationship, but enhances it. Generally speaking, when you refer a patient to a different professional, like a social worker or a mental health professional or a lawyer, you never know if the referral was made. With DULCE, you can close the loop. It's really strengthen the relationship they have with our primary care practice, with the pediatricians. They get to understand that we are a team and we're working together as a team, and so we're sharing information and knowledge across our team so we best can support those families. The value of the interdisciplinary team is of great help. As a team, we're able to look at each individual case and to see what area of expertise the case needs. To have on board a social worker, a family specialist who knows the family, a hands-on pediatrician who knows the baby, the MLP lead who's able to bring her legal perspective into it all is definitely a plus. It is very important that we all have our input and see how best we can serve the family. But it does bring value. We want to wrap you in as much as we can for the first 6 months of your baby's life so that you are as healthy as you possibly can be. And for some families, it's a stress relief to know there's someone I'm comfortable with that I can reach out to that's going to provide me with some support or point me in the direction where I can receive support.
Okay, thank you. I'm going to hand off to Bob Sagi to present his slides now. And Bob, we can see your screen. There you come. And we can't hear you yet if you've been speaking.
Okay. There you go. I took myself
there you
off
are.
mute.
Great, thank you.
I'm just catching up to where we are, and there you go. So I want to go over a few of the special things about DULCE in this talk. First of all, DULCE focuses on the first 6 months of life. And we do that because there are challenges for families. Families with infants face predictable stressors, both because the baby is crying and all those things that go on. The family system itself changes, of course, and there's economic and social stress on the families. And because of that, we know this is a high-risk time for severe and sometimes lethal child abuse. There's also an opportunity. Almost all U.S. families of all races, ethnicities, and socioeconomic status bring their infants in for routine care after discharge from the nursery. Practice guidelines include assessing and addressing the social determinants of health and maternal mental health as part of routine infant care. And in many parts of the country, patient-centered medical home model has been adopted, and this provides for team-based care. So at a DULCE visit, each visit is patient and family-centered. The content of the visit follows directly from what Bright Futures, which are the guidelines for infant care, incorporates the touch points approach to mother-child interactions, and the medical legal partnership approach to concrete support. Within the visit, each topic, there's some general considerations, considerations about the baby, the family, the mother's health, and concrete support. And we'll get back to this, but we also suggest that the family specialists prepare for the weekly case review immediately after seeing the families. If we focus for a minute on what are the screening aspects of DULCE, every DULCE site has to do core evidence-based screens. There are concrete supports, food insecurity, financial and employment, housing stability, housing conditions and utilities, and also 3 screens involving family maternal health, intimate partner violence, maternal depression, and parenting support. And this may ring a bell for those of you who are familiar with Bright Futures and EPSDT guidelines. Many of these are also included in those guidelines. But what's amazing about DULCE and what we really have worked so hard on is that we go from these evidence-based screens. The second step is an initial response. And before DULCE starts at each clinic, they develop a process map. What do we do if a mother scores a certain amount on the PHQ-9, suggesting that she's in trouble but not suicidal, or obviously if she was suicidal? How do we address food insecurity with the local resources? And those process maps are put together by the DULCE team that includes the health center staff and also the early childhood system staff and also the medical legal partner. So they're pretty robust process maps. Every week, there's a 1-hour case review, and this is an opportunity for collaborative problem solving. I'm sure it's no surprise that many of our families run into trouble, even if we have a process map that's well thought out. And collaborative problem solving with a mental health person, a physician, a nurse practitioner, the family specialist, and a lawyer or legal expert, and in many communities, someone from the early childhood system as well, going through these cases for 1 hour a week, every week. And then once a month, there's a quality improvement. The weekly case review is populated by the family specialist, by a physician and nurse practitioner from the clinic, a legal partner, and a mental health clinician. And the goals are collaborative problem solving to identify and address systems issues as they arise. And this is so powerful that many of our sites consider this to be the secret sauce of DULCE. At monthly CQI meetings, we use the clinic's own QI system, and we add on to it the DULCE system so that we can begin to track how DULCE works. And physicians, pediatricians in particular, are required to use something called MOC Part 4, and DULCE helps with that. So I want to turn for a second to say, why do we think DULCE works? And DULCE as intervention is really at the nexus between the early childhood system, the healthcare system, and the legal system, because our goal is to improve health and well-being by transforming the way that families experience the delivery of supports and services from the moment their children are born through this cross-sector collaboration between pediatric, legal, and early childhood systems. DULCE works at the practice level because the family specialist is part of the primary care team. She, in fact, is in the exam room with the doctor, nurse practitioner, and family, and spends a great deal of time with them at each scheduled visit. There's universal access during a child's first 6 months of life. This is important both because we know from experience that we can't really identify all the high-risk families as much as they can identify themselves, and secondly, because by offering it to every family, we completely eliminate stigma. So in this model, families determine the supports they receive through their answers to screening questions, their relationship with the family specialists, and their own readiness to get extra support when they need it. And of course, I've mentioned the weekly cross-sector case conferences. At the community level, DULCE is driven by the early childhood system, and in fact, the primary contract is at the county level, so the multiple clinics in the same county may be implementing DULCE at the same time. And what this does is it leverages overall community investment in early childhood, health, and legal sectors for children. So the multi-sector collaboration really meets the mission and capacities of each system. The early childhood system is accountable for young children and their families. It's immersed in the community supports that address, among other things, social determinants of health. Early childhood systems are familiar with evidence-based and evidence-informed programs, and they often have influence on policy and practice within their communities in the larger political structure. What healthcare brings to the table is almost universal reach in this 0 to 6 month age group. They have long-term relationships with families. As an example, one of our family specialists was a child treated at the clinic where she's working. Her own children were treated at that same clinic, and now she's back in this professional role. So there is a long-time relationship. We take great pains to train the family specialists so that they become experienced and use standard protocols to improve the quality of care. And that fits well within what healthcare does, which is there are many people, nurses, doctors, medical assistants, administrators, who are familiar with using standard protocols to improve the quality of care. And for the most part, healthcare is trusted. Parents are considered good parents if they bring their care to clinic. There's no stigma associated with bringing a child in for care. The legal system is well versed in family rights and systems responsibilities. They have a professional orientation toward problem solving and advocacy. And what they bring, and we've seen this over and over again, is an understanding of policy that brings a policy lens to the issues our families face and expertise to help them address this. So as Patsy mentioned, I was the PI on a randomized controlled trial in Boston, and we were able to demonstrate that we reduced emergency department utilization among DULCE families. One thing that many people are not aware of is one of the main reasons people bring their infants to the emergency department is because she's not acting like herself or she's crying. So we think that incorporating the touchpoints approach and helping parents understand their child's development reduces some of these needs. We've shown improved on-time well child visits and immunizations, greater access to concrete supports, and accelerated access to some supports. So our families got the supports they needed in 6 months instead of 12 months in the control group. Now, as we move around the country and we do the pilot, we found that family participation and completion rates are high. 98 to 100% of families agree to be part of DULCE, and 87% complete it. And the reasons they don't complete it is typically because they move out of town or out of the catchment area of their clinic. And we find that from the county's perspective, DULCE gives communities another option to meet the diverse needs and interests of families. For example, some home visiting programs focus on the first child of a young family, and DULCE focuses on everyone and then uses that to find out which families need more help. But I think that the family's appreciation, things like my confidence as a mom has improved, which helps me express our needs as a family better, and I understand changes and how to address them. I know when I'm getting overwhelmed, need a break, and always make time to relax. This is the key. This is what we're seeking, and what keeps us going is the family's response and the family's appreciation of the benefit. From the practice point of view, because after all, the practice is where this is hosted, it's led over and over again to an improved work environment and provider satisfaction, decreased emergency department visits, better on-time well child visits, decreased no-show rate, and effective implementation of some of the challenging Bright Futures and EPSDT guidelines, particularly those that address maternal mental health intimate partner violence, and social determinants of health. One of our physicians, after being in Dulce for a few months, told us, "This is why I became a pediatrician, to address the things that really matter for families and children. Through Dulce, I can." Legal partners add something really special to this, and here are a few quotes from our legal partners. "By participating in case review, I was able to spot a potential family where both parents may be eligible for naturalization. Before this, the family specialist was not looking for potential naturalization, and this allowed me to inform her about another type of service we can assist with." Another quote, "We were able to take on a case through Dulce that pinpointed several problems with Medicaid coverage of transportation issues, an issue that our office has been working to fix on a systematic level. Transportation has been a big issue, so we often partner with the clinic to assess the ground level impacts of the policies and in return report the issues back and litigate if necessary with local and state entities. As a result, the state agency overseeing Medicaid managed care plans has opened up its case via the Office of Enforcement to investigate the plan's transportation services. We'll report back to the clinic." I want to focus on that last one because what we found is that because the lawyers were there in case conference, they identified this issue. But when they're successful, and we believe they will be, they will improve Medicaid transportation for every child in that county, well beyond the ones at the specific Dulce clinic. And we also found that for the early childhood system, there's stronger connections between the early childhood system and the families, and that the early childhood system knows about benefits, early child education, family support, home visiting. Our family specialists work with other siblings and help with transportation and connection. And they know a lot about immigration supports and remedies. So these early childhood system supports become available to families through Dulce and the family specialist. And here are some of the results. We use Dulce quality improvement methods to partner violence. 93% were screened, and of those who screened positive, 2/3 were connected to services. And I want to turn it back to Patsy to talk more about Dulce and where we are now in the implementation, dissemination, and expansion.
Patsy, you can go ahead. Maybe on mute.
I was on mute. I was talking away too. I just wanted to share that at the end of our call, our conversation, we'll have a chance for questions and answers, both in terms of the nitty-gritty of how Dulce works, as well as what you might do if you're interested in Dulce. So I want to show you on the next slide where we are currently. So the purple dots are where we currently have Dulce sites. We're in 5 communities in a growing number of clinics. We're actually onboarding 4 sets of new clinics now, 3 in Vermont and 1 in Orange County. So we've gone from 7 clinics in 5 communities to 14 clinics in 5 communities. So we're very excited about the rapid growth within those places where Dulce is happening. And we're at a point in time where we really wanted to grow and explore this work with other communities. So these parts of the country that are highlighted, that have green dots, reflect some of our current EC Link communities, as well as just calls that we may have fielded from interested stakeholders across the country. But we're really interested in thinking with other communities about what it might take to bring DULCE to your state or to your locality. One opportunity that you'll be hearing from us on as a result of this call as follow-up is we every year have a national forum where we bring all of the DULCE teams together to learn from one another about their experiences with DULCE and also to work on how to improve their intervention and also just to celebrate the work that they're doing. Last year we opened that forum up to a couple of communities that were interested in exploring DULCE. And this year what we will be doing is sending out an application for communities that are interested in bringing some stakeholders to the DULCE forum to learn more about it and how it might play out in their community. So we'll have an application process with some pre-work that we might ask you to do before you come to the national forum. So that work is in development now, but you'll the Strengthening Families Network will be part of the outreach that we do for that, and that'll be a May forum that will be held in New Orleans. So one of the things that you'll see on the slide coming up is where we are now with our expansion. We last year embarked on a 6 to 8 month process to develop a business plan. So as we knew that DULCE was successful in 5 places, and we also knew that we needed to be very strategic about how we thought about our expansion and how we grew the work. So we set 5 big goals for ourselves. One is to build and diversify the DULCE network of cities, counties, and clinical sites. So we want to be in at least 10 different cities and counties over the next 2 years. We want to develop an efficient and effective model for providing technical assistance to communities implementing DULCE. That includes both support for learning, continuous improvement, and innovation across the network. We provide a good bit of guidance and technical assistance to our DULCE sites. In addition to the national forum, we have routine learning network calls. We also do some individualized onboarding to sites coming on new to DULCE, to their full teams. We also use continuous quality improvement, as Bob said, to foster the learning and the implementation. And we're interested in innovation across the network. Several of our sites that have been doing DULCE for a while are very interested in thinking about how can they start prenatally and thinking about how they partner with some of their OBGYN clinics or in the same building, or with some prenatal approaches that can bring DULCE to families early on. So we're very much interested in that innovation. We're very interested in what DULCE looks like in rural areas as opposed to urban areas. And so really looking at a broad range of diversity of sites across the country. The third goal that we're focusing on is building a strong funding, a base of funding resources, both locally and nationally. And I'll show you a slide in a little bit that shares what some of those funding resources might be at a local or state level. And then we're also continuing to grow the evidence of DULCE, looking at how we can build the evidence of DULCE and DULCE's effectiveness through the publication of journals and the collection of data. Let me go to the next slide that actually will show you let's skip that one and go to the next one. That shows you some of the key performance indicators that are helping us build the evidence for DULCE. And this also gives you an example of, at a local community, some of the data points that you would get on a routine basis. So you would know how many families were enrolled in DULCE, how many families were new. We have a very high attrition rate, retention rate, as Bob referenced. We are very successful at well-child visits happening on schedule. For our screening, we are able to show what families were screened positive for something, what needs they wanted addressed, and how those needs were addressed. We have reports that are coming in process where at the 4-month visit, we reassess what needs are being met by the family, for the family, and what some of their outstanding needs are, and then make some changes in their work to sort of address those needs by the 6-month exit visit. We also are keeping track of those extended needs that families have beyond the 6-month visits. There are some needs that can't be addressed in a 6-month period of time, or some needs crop up at the end of the intervention, and will continue. The family will continue to need support beyond that 6-month period of time. And as part of that, we're tracking what are those service gaps and barriers that the legal partners in partnership with their early childhood leads can address. So this data is how, as Bob mentioned early, we knew that families were, that children were losing their Medicaid access between the 2-month visit and the 4-month visit, and counties were able to make some changes that impacted not just the DULCE families, but the other families in the clinic and across the county. And that was a result of the data that we're collecting and the performance measures that we are also collecting. Another story about this data and how it results to a systems change is in our Palm Beach site. They were noticing that families were not showing up for their well child visits, and so the family specialists reached out to the families to get a better understanding of what was getting in the way, and transportation was coming up. The community does not have a very strong public transportation system. The wait times in the clinic were very long, and transportation was unreliable. And so the early childhood system was able to actually set up a transportation service contract for families enrolled in that clinic. So that's another way that we use data to improve service and system outcomes. So one of the questions that we get asked, and the next slide tells you a little bit about what does DULCE cost. And so I know that as you think about how can we bring DULCE to our locality, one of the things that come into play is just what does it cost? And as we did our business plan, we did a sort of a study of clinics grow as you add family specialists, but that's a baseline cost. We serve between 120 and 160 families a year, depending on the clinic size and the intensity of needs in the clinic population. The costs vary, as it says, by size of caseload, by the legal partner cost, and just local variations in the approach. We actually like local variations in the approach. We say that we want folks to implement DULCE with an eye towards fidelity and adaptability. So we, DULCE, Bob and I were just talking earlier, DULCE has these very concrete things that we want you to do, and it looks different in different places because of the personality and the culture of the clinic and of the population and of the community. So we like that about DULCE. In terms of the cost, some of the roles can be covered by existing positions. The project lead often has dual roles within the early childhood system. And just a point of note in that the family specialist is typically hired and added to the clinic team. In most of our current cases, it has not been an existing employee, but it can be in some sites. So on the next slide, I'm going to show you a little bit about where some community resources for funding might lie. And we at the National Center or at CSSP are really looking at these funding sources along with our partners at the local level. So public dollars, I think you all know about these. If you've got local early childhood system funds that are devoted to cross-sector early childhood collaboration, DULCE is a great resource for that. Home visiting dollars, the child abuse prevention funds, Title V, FQHCs, affordable Medicaid, accountable care organizations. We are exploring with our current site what this funding would look like, recognizing that public funding streams take a while, especially when you're thinking about Medicaid or changing the rate of a federally qualified health center. There are just some ways that those things take a while. So we're exploring with our site, and we're still learning with our sites about what that looks like. We do have a set of financing materials that I'd be happy to share with any of those that are interested about how you might be able to draw down funds through Family First or through thinking about some of your federal funding streams. And there are also local resources, both through local foundations, community benefit programs through hospitals and health systems, United Way, pro bono legal support is also helpful. And then with some of the primary care and perinatal associations, and also private insurers. So in Vermont, the Accountable Care Organization in Vermont has made a commitment to fund 4 new DULCE sites over the next 2 years, because they were so impressed by what was happening at our pilot site, and because they could make the direct connection to DULCE and a piece of legislation that talked about how there was a need to mitigate toxic stress and reduce adverse childhood experiences. And so the Accountable Care Organization came to the table and was, is funding DULCE in Vermont. So that's a very concrete example of that. The other example is you'll be getting some guidance from us in the next few days from CSSP about the preschool development grant opportunity that has an expanded opportunity at state levels to expand the work within that grant. And there, excuse me, there's some opportunities for DULCE. So let's close out and maybe have some questions. I'm going to grab some water.
Okay. Bob, do you want to talk a little bit more about these concluding words from families?
I had to unmute myself. I think we always like to finish with families because families are the reason why we do this, and the overall way DULCE works is it takes the complex early childhood system and makes it really simple for families. They just bring their kids to clinic, which they already do, and we take on that complexity. And listen to what the families say. Our doctors' visits turn into more about how things are going and what to expect. And we heard this before. My confidence as a mom has improved, which helps me express our needs as a family better. I understand changes in my child and how to address them. I know when I'm getting overwhelmed and need a break, and I always make time to relax. Think of all the difference this can make for families of infants, and as they go on and continue to utilize these new links to the community. And this is what keeps us going on DULCE, and we really are looking forward to some questions and discussion now, and hope that many of you will think about implementing DULCE in your own communities.
Wonderful, thank you. I will go ahead and read off one comment that was put in and encourage folks, if you have something you'd like to share, a question or a comment, you can type it in the question box and we can read it off, or you can raise your hand if you are in the spot where you could be unmuted, and I will be happy to do that so that you can speak your question. We had a comment from Barbara Christensen who said, Ventura County Public Health Nurse in Child Abuse and Prevention here. Excited to see our community here as a prospective community and going to be investigating where this connection status is at. So we've got a few more questions coming in. Bob or Patty, do you want to say where that connection is in Ventura County in case Barbara could connect to them?
Sure. So Ventura is an EC-Link community, and early on when we were implementing DULCE, in the beginning, there was some interest, and I think that there still is that interest. I think that it would be worth exploring with First Five what they think about the intervention, how it perhaps fits into their strategic plan, how they might be interested in partnering with you and others. I would also suggest that you might reach out to your local public interest law, like a legal aid group in Ventura, to kind of maybe have a conversation about what DULCE might look like in Ventura. One of the things that Bob and I, with Samantha, who's on our national team who represents the legal community, we're available to come to local communities to have conversations with interested stakeholders, to share more with your larger community about DULCE and how it might fit into your existing set of systems and services, and how it might complement what you already have and meet a need.
Great. Thank you. All right, we've got a bunch of questions got typed in. Thanks, participants, for being very engaged. We have a question from Sherry Jo McLemore. How are pediatricians able to create the time in their practice for these more extended meetings with families?
Oh my God, I am so glad you asked this question. Because what we found is it does not increase the time that the pediatricians spend with families. It increases the effectiveness. So what we think about is, those of us who are healthcare providers think, oh, it's a 15-minute visit. But if you're a family, you may be at the clinic for half an hour, even more. And the family specialist uses all that time. So we found is that the pediatricians focus on other issues. They know the screening is being done. They're able to respond to the screening. And they're also able to pick up on issues that need discussion, that the family specialist helps empower the parents to ask. All of us in practice know about the famous doorknob question, which is people are a little reluctant to ask something, and then they're about to leave and they know it's their last chance, and then they talk about the real reason why they're there. And we found that having the family specialist empower parents, activate them for the visit, just makes the visit much more efficient. And in fact, in some of the clinics where there are incentive systems for volume, they have an issue because the doctors who have DULCE are able to see patients more efficiently and effectively than those who don't. Families at a time. Obviously, most of those are low-intensity families. But in some clinics, they're sharing family specialists between two small volume clinics. And we're absolutely looking for clinics where they might want to have someone who has an existing outreach job who would learn DULCE and be able to use that for the smaller number of babies. So we're very open to how to accomplish this in a way that's cost effective, but every family receives the intervention.
I would, Bob, that's exactly how I would answer it. I think that we are interested in those smaller clinics that serve, maybe 50 or 60 newborns a year, ways in which we can train them to do family specialists in addition to another position, so that it makes it effective for them. And so we're testing that out, and I think in one of our Vermont sites is where they're sharing a family specialist. So, or the family specialists have other responsibilities. So that, I think, should not be a limiting factor in whether you do DULCE.
Oops, now I was going on mute. Okay. We've got a couple questions about your evaluation findings. The first is, were you able to tie this program to reduced child maltreatment or entry into the child welfare system?
Our funder has hired Chapin Hall to do an independent evaluation, and they'll be looking at that sort of question. We hope it will work. When we did the original randomized trial in Boston, the numbers were simply too small to look at that. So that is, of course, the goal. And we know this is a highly vulnerable population because they're so young.
Okay, and I'm going to read another related question, and then I see that Antoinette has her hand up, so I will unmute you in a moment, Antoinette, but let's ask this other question first because it's related to evaluation. It says, this is from Auburn Watersong. For state funders who want to see an ROI, return on investment, when you are asked, how can we prove this amounts to cost savings in the long run, how do you respond? Do you have any data or numbers at this point?
We have lots of answers. So we know that when we had a consultant do an analysis in California, and they thought that about half of the cost of DULCE could be directly saved from improvements in efficiency in Medi-Cal, with issues like addressing maternal health being one of the drivers of those cost savings, decreased costs for chasing families who were behind on checkups or immunizations and other quality metrics. But I think the other question, and I really like to talk to policymakers about this, is that we think DULCE is the most effective and efficient way to achieve these important family outcomes, and that we are providing something that's of value to families and to communities, and it won't be free because we're going to have better outcomes for less money and other ways of achieving it. So it ends up being a pretty complicated conversation. Patsy?
I think you answered that well. I think that's right.
All right, thank you. I'm going to unmute Antoinette for the question that she wants to ask. Let's see. Antoinette, can you try speaking?
Hello, can you hear me?
Yes.
Okay, great. I didn't know if my headset would work. So I'm a family engagement specialist for the state of Michigan Department of Education Office of Great Start in Lansing, Michigan. However, I live in Grand Rapids, Michigan, which is Kent County. And I saw that was on your list of possible connections in the future. And I was just curious if you had sort of like a time frame of when you were thinking of implementing this. I know it would be great. We have some great programs that would really benefit from, is it DULCE? Did I say that correctly?
It depends on whether you're Italian or Spanish.
So the answer to that one is very similar to the Vermont answer, and the Ventura answer, sorry. Grand Rapids is an EC-Link community, First Steps, and they have expressed some interest. We've had a couple of very preliminary conversations with them. So it's a place where, we're interested in seeing where that interest, how that interest grows. I think that as in every place there's a, they have their own timeline about how this fits into their strategic plan. And their work. So there isn't a timeline that I know about for Grand Rapids, but there are one of the sites who have expressed interest in the past through EC-Link. But I would encourage you to reach out to your partners at Great Start in Grand Rapids and in First Step.
Okay, thank you. I appreciate that. That's all that I have. Thank you.
Thank you.
Kaylin?
Kaylin, are you on mute?
Oh, yeah, I've been talking for a long, long time. I'm sorry. I was saying that I hoped we could go a couple minutes longer to answer a couple more questions, if that's all right.
It's fine with me.
It works for me. Yeah.
Okay, and we'll keep recording. So for participants who have to jump off for another meeting, you can do that and come back and listen to the recording afterward. But there was a question from New Jersey asking about how could we learn more about bringing DULCE here. And so for communities and states that are not part of the EC Link network, what are those opportunities going to look like, and how can they find out more?
I think we would love it if you would just follow up with us after this call, and we can do a number of things. We can have a more tailored call with some of your partners or just with you to explore more. We can come to you if you want to bring together a group of stakeholders that represent the early childhood system, the pediatric healthcare world, and public interest law, and thinking about what it might look like for you. We have a developing website where we're continuing to add materials, and so we can send you materials. But yeah, I think one of the first next steps might be just a call to learn a little bit more about your interest and and who your partners are, and thinking about how we can explore that with you in your state.
Great. Okay, and we've got a couple more about the model itself. Sherry Jo is asking, what is the education level and experience level of the family specialist?
Most of our family specialists have worked in the community. There's no specific educational requirement. Many of them worked in early intervention or other community outreach prior to being in DULCE. We leave the hiring to the local sites, and some experience with young children and their families is obviously required.
Great. And then we've got a couple questions about the legal partners. One question was, who are the legal partners and are they compensated? And then another one related was, since some legal aid programs are restricted in what types of legal help they can provide, and here she says LSC funded, were you only working with those who are not LSC funded, or are you working around that?
So I can start, and then Bob, maybe you can follow up. Our legal partners are they're varied. They either consider themselves to be a medical legal partner, or they are folks who are part of legal aid or another kind of public interest law group. They are compensated. There is a budget line item for their time. And refers the family to another legal resource that can do that, but they serve as a go-between to kind of link families to those legal services that they may not be able to address themselves. But I just want to say that a lot of the work that our legal partners do is very much in the preventive stage, and most of the time the family may not even meet the attorney. The legal advice and the legal sort of preventative work is done through the family specialist and that family specialist relationship and training and support with the legal partner. Bob, would you add something to that?
I just want to, when Samantha Morton, who's from MLP Boston, is leading the MLP part of what we do, so it differentiates between legal information and advice offered to the team and direct representation for the families. So our legal partners really function in terms of providing information for the team, in some cases taking on legal issues that affect many people in the community, but individual families who need representation are typically referred maybe to an LSC or somewhere else to get the representation they need.
Okay, thank you. We're going to take one more question from Paula Cunningham. Whoops, I didn't mean to, well, I'll I'm trying to scroll through questions and scrolling slides instead. Question box is hard to read. Paula Cunningham asked, what people or groups of authority generally need to be involved to effectively start DULCE in a community?
So it starts with an organization that you would consider to be an early childhood cross-sector backbone organization. It looks different in different places, but basically, you know, one of the leaders in the local early childhood system work, an interested pediatric clinic or partner who's interested in doing innovative work that might be representatives from your local AAP, but it also may be a clinic that you've identified. And then either connections to or a partner that you know through a medical legal partnership or public interest law that you've got a legal partner or access to. Those would be where I would start. Bob, would you change that?
Yeah, I think that we can help give you advice on forming a coalition. So if there is an early childhood agency, which will be the backbone for this, we can often help them through their AAP or whatever, identify the clinics. We have criteria for which clinics might be the right ones. And I know that Samantha has figured out sort of what are the characteristics of a legal partner that might enable a site to find such a partner. And I say that because often these alliances don't exist before DULCE. And one of the long-term advantages of DULCE that we've seen over and over again is starting with this process for kids from 0 to 6 months. There can be additional collateral partnerships. So in California, one of the legal partners has an immigration clinic that they set up, not limited to DULCE, but because they identified that need and they got private foundation funding to run that. In other places, the clinics have established better relationships with the early childhood system that help when children age out of early intervention and go to the schools or need home-based services or those sort of things, even outside the 6-month program. So we're happy to help you brainstorm where you might find partners and use whatever networks we in the existing DULCE sites have to help identify them.
Great, thank you. Those are all our questions. I appreciate staying on a couple more minutes to get those final questions answered. I always say you can't talk about DULCE for like 10 minutes because you will have a half hour of questions and follow-up because everyone is so excited about this intervention. So many, many thanks to Bob and Patsy for joining us today and sharing all this great information. And as Patsy said, we will get information out through the Strengthening Families National Network, those newsletters and other, those announcements I make at the beginning of future webinars. We will let you know when there are opportunities to learn more about DULCE or to get connected to it. And I hope that a lot of you will take advantage of that. I think it's a great model. Thanks so much, everyone. Thanks, Martha, for the updates at the beginning and your partnership as always. And I hope that you all have a great rest of your day.
And thank you for inviting.
Thanks, everyone. Thanks, Kaylin.
Thank you,
everyone.
Bye-bye.
Bye, thanks.